Physical therapy is built on helping people move better and feel better. But what happens when the science behind what we do gets murky? In this episode, Alex and I are sitting down with Paul Ingraham, science writer, former massage therapist, and founder of painscience.com, to talk about the critical distinction between evidence based practice and pseudoscience in physical therapy. We're highlighting the challenges that clinicians face in navigating the often ambiguous landscape of treatment efficacy. Paul emphasizes the importance of recognizing the limitations of current research and the necessity for clinicians to maintain our intellectual humility as we adapt to evolving evidence in our practice. We're also touching on the economic pressures that can lead to the perpetuation of pseudoscientific practice in healthcare, and we're underscoring the need to shift towards value-based care that prioritizes and rewards patient outcomes over volume of services provided. We're covering some hot takes like why manual therapy needs reframing, and we get specific about that. Why boring basics like exercise and strength training still win, and specifically how you can reconcile honest patient care with the economic realities of running a practice. So if you've ever wondered why you're doing something because it works or because it pays, the conversation we have with Paul will make you think twice, we think, and hopefully give you a path forward if you're looking for that. Paul doesn't pull punches, but he doesn't leave you hanging. There's hope here for clinicians who want to practice with the highest integrity, communicate transparently with patients, and still keep the lights on. Hello, everybody. Welcome back to Future Proof PT. We have episode 25. It's a big one here, and we are so lucky to have Paul Ingraham with us.
So, Paul, thank you for being here and thank you for dedicating your time to this, to our little passion project. So, just a quick introduction. I think Paul, to me, has been the foundation of truth as I train young clinicians and young therapists as they rise in a profession. So, Paul has done an exemplary work on pulling evidence and questioning some of the existing data and some of the existing practices, substantiating those questions. So Paul is been a resource and really a leader in a space of evidence-based practice, but also a leader in a space of value that musculoskeletal care can provide under the right conditions and under the right circumstance. So with that, Paul, can you introduce yourself also and your journey here?
Sure. Sure. Yeah. I am Paul Ingram, and I am the writer and publisher of painscience.com. I used to be a massage therapist. I transitioned to science journalism in 2010, and I've been doing that ever since. And so my job is to think about this stuff all day long, every day.
And thinking you do. So you have a paintsize.com. That's your medium. That is your outlet into this world. And
Yeah.
what caught my attention, especially just recently, is your post about science versus pseudoscience and is physio a profession in North America, at least, right? So we can just talk about local. Is it inching closer to pseudoscience based on current practices and based on what you see? So can you just elaborate first, painting the picture of what is a definition of science-based practice versus pseudoscience, and why is physiotherapy on this at this risk zone of being more pseudoscientific than scientific?
What is evidence based practice? What is pseudoscience? Was that the question?
Yes, sir.
Pseudoscience is hard to define. It's like pornography. You know it when you see it. But you do need a good knowledge base to recognize it. And a certain amount of expertise is required to spot the signs of pseudoscience. Evidence based practice is prioritizing that which is evidence based in clinical practice. Evidence based being scientifically plausible and at least to some degree confirmed and supported by good quality research. And the number one problem with that is that there is surprisingly little good quality research. That's the stumbling block again and again. It's not just that things need to be based on evidence; they need to be based on evidence we can actually trust, and that is a high bar. Hard to find that sometimes. So there's a big absence of evidence problem, which is where most people get hung up on evidence-based practice. It's hard to find evidence to support much of anything. Clearly, not because the evidence is negative, but because it's often just missing.
Yeah, the lack of evidence or evidence lacking, right? So I think the substance of this present medium of this podcast is value-based practice, and the way we define value is outcomes over cost, right? Like so the value is based on clinical outcomes, and clinical practice has to be substantiated on some form of evidence, even if it's the lowest threshold of evidence, right? So the level 5 evidence, which is expert opinion. I know it works, therefore it works. And then from there, you go into that pyramid of empirical evidence into that, like that gold standard of these large data sets and systematic reviews. At the same time, do you think there is a ratio, or is there a percentage of substance to pseudosubstance that can be tolerated, or is it just black and white? You are either evidence-based or you are not evidence-based.
Oh, no, there's no line. It exists on a wide spectrum. There's everything from fraudulent science at one extreme to completely cromulent normal science that just happens to be wrong on the other. And good science is wrong sometimes. Just because science says something doesn't necessarily mean it's right. And there's everything in between. There's also the role of intention makes things very ambiguous as well. And this comes up in anti-quackery activism all the time. People want to know, is it fraud, or do they really believe that homeopathy is effective? And I think the answer is that almost everyone selling anything that gets called quackery actually believes that it works. That is probably almost always the case. It's usually earnest and well intentioned. But the point is, we never know. There's no way to ever be sure about anyone's intentions. We're not mind readers. And the same question arises in pseudoscience. Is bad science deliberately deceptive and misleading? Is it a marketing exercise, for instance? They know that they're just padding their resume and creating something that will help sell the service. Is it cynical, or is it well-intentioned? And we can never know. And if we did know, it would be an instant, it would give away the game right away if we knew that they had evil intention, but we never do. And so that makes things always ambiguous. We're never quite sure whether we're dealing with pseudoscience or how intense the pseudoscience is.
Except when it's like pornography and you know it when you see it.
Except then, yeah. I mean, I say that as a joke, but there is a truth in it as well.
Oh,
I am well aware of many red flags for pseudoscience that most people probably aren't aware of, because I deal with the subject matter all the time, right? I know a lot of subtle red flags that most people have never even heard of. So that enables me to spot stuff that, I'd take one look and I go, yeah, I see problems that other people might not.
But even on the less extreme part of the spectrum, the point you made when you first started about, patients don't necessarily, or the public doesn't necessarily know how to spot pseudoscience is one of the biggest risks in healthcare in general, right? There's no good barometer. Patients don't know what value is. They don't know if their provider is even a mainstream medical provider. They're suggesting doing something. They can suggest anything. They can suggest something that's pseudoscience, that's science-based, but not good for them in particular, or may not align with their goals. That may not be pseudoscience, but it may not be the right science for them. So there's this wide spectrum, and the general public may be better at spotting some of the real extreme pseudoscience, snake oil stuff, and not so great at that middle of the road where it's going to work for some people and maybe the right thing, but this particular approach may not be what's best for this individual.
I was going to add that I invented the idea of pseudo quackery precisely because of this, because there is this huge gray zone where the quackery isn't obvious. And something that people underestimate is that the whole job of pseudoscience is to seem like science. That's the point of it, is to seem legitimate when it's not. And so the result is that we have an awful lot of stuff that easily passes the sniff test. Most people's bullshit detectors aren't tuned to catch most of this stuff, and that makes it very sneaky.
So I'll give one example, and then I want to hear both of you guys reflecting on this. And that is going through the evolution of my own personal professional development. I followed the typical trajectory of going through physical therapy school, graduating from physical therapy school, going through the development, going through that certifications, after certifications, going through the fellowship training. Each step of evolution was indoctrinated in this single point philosophy, right? So the single point, very much James Siriach's based biomechanical thought process, very much see bone, crack bone, fix problem. But then there was a natural evolution of this just doesn't sound right. And are there other philosophies that can complement my delivery of care? And that's where you start to explore pain neuroscience, and you start to read literature, and you start to grow and develop. And at the same time, there was a co-evolution of other professionals that became SI joint specialists, or they became fellow clinicians with specific philosophy. And they never grew. Once they received those letters after their name, that was it. So they never updated their core beliefs. And even if there was some substance to their core beliefs in 2005, there was no longer substance in 2015. So question for Dana related to value-based care, and then question for Paul related to science-based medicine. How have both of you grown and evolved professionally, with Dana with value-based care and updating the core beliefs about value-based care in the United States, and Paul about your fundamental beliefs about what does good science look like, and where are you now compared to where you were 10 years ago?
When I think pseudoscience, I guess I'm more apt to think about assuming that some of the things that we're talking about in pseudoscience are more on the extreme, and that we're just gonna, like, the kind of people that are gonna be duped by that kind of pseudoscience, even though I know that's not true. People are duped all the time. There's a whole industry around it. When it comes to, what value-based care promotes, such as what it promotes in primary care, it calls out some of the deficiencies in, how to provide standard practice for caring for patients for chronic disease, for example. I mean, the Canadian system, I can't speak to it because I don't know how it works exactly, but in the American system, you have to do, it's a capitalist system, and the more providers do, the more codes they bill, the more money they make, and there's not codes for doing things that are good for people on a primary basis. So, preventive care, care management, coaching, education, anything that's really evidence-based, we know it works. Value-based care is shifting that. It's saying we're gonna come up with alternative reimbursement arrangements and different incentives so that practices create the structure to help manage these patients. First, to get their preventive testing, to identify diseases early, to help them manage those diseases, to keep them out of the hospital. So I kind of think about value-based care as a deep incentive against pseudoscience, and it is a strong incentive to practice evidence-based medicine, providing that different reimbursement structure to allow those systems to be developed. I think less on a day-to-day basis about some of the more extremes, the snake oil stuff, even though I know they're not extreme and that we spend billions a year on, products and services that are not going to yield what we imagine they will, but because they're potentially easy or, whatever the case may be, why we trick people. I'd love to hear, Paul, from you, and I'd love some examples of the kinds of things that you point out, because I haven't had the pleasure of reading a lot of your work.
I can, and I have listed many examples of things that aren't really evidence-based, don't constitute good evidence-based care, but most people would not recognize them as quackeries, which is why I call them pseudo quackeries. And I didn't recognize them as pseudo quackeries for much of my career. I think we got into this part of the conversation, Alex, because you asked about change over time, how it got here, and it's almost entirely about comeuppance and humility and discovering that I was wrong about stuff or might be wrong about stuff. I had the very strange intellectual misfortune of reading Carl Sagan's Demon Haunted World as I was starting a career in alternative medicine. It's very, very weird timing. It got me asking awkward questions about my new profession as I entered it. This would be back around 2000. And I just fell down the rabbit hole of discovering that I was wrong about a lot of things, and it never stopped. To this day, I discover something I'm wrong about on a regular basis. This field is complicated, and it is impossible to be intellectually honest without stumbling on your own errors and oversimplifications and misconceptions. I've been on multi-year journeys down what I now regard as dead ends, including what many people would consider to be progressive physical therapy. So to get specific, I am now backing away steadily from pain neuroscience education, which many people regard as a paragon of progressive evidence-based physical therapy, that it is in fact the answer and the alternative to the wrongs of the past, that it is the way to move forward. And I'm not going to categorically say that it's not. I'm not going to call it pseudoscience or quackery, but I am going to point out that it's not aging well. And I am no longer comfortable endorsing it because I just don't think the evidence is there. I think as time goes on, we see a more and more suspicious absence of evidence, and what evidence there is for its efficacy tends to damn it with faint praise and be rather suspiciously unimpressive and flawed. For years, I endorsed, I just flat out endorsed it.
Mm-hmm.
Because I saw it as a clear progressive alternative to all of the things that I had started to criticize in the field. And now I'm backing away from that. After years of endorsing it, that's awkward. I mean, that is intellectually uncomfortable. I wake up at 4 a.m. thinking about it sometimes. So my journey has been, all about discovering just how much I don't know. And doubling down and continuing to go further and learn even more about what I don't know. I definitely have a problem professionally with the paralysis of being uncomfortably aware of how much there still is to learn. Makes it difficult for me to be definitive or confident about things, because it seems like every time I get confident about something, I regret it 6 months later. If not 6 hours later.
It's the half-life of truth. I forgot the name
Right.
of half-life of, right. So all of the organic materials, and this, he's a data scientist. He works for Google, or works for Google. So very smart guy. And the book is essentially that. It's that, all science, every scientific philosophy has a half-life of truth. And I think psychology has the lowest half-life, 3 years. Within 3 years, it does full 180. And then something like physics and mathematics is like a 15-year turn. But all sciences have a half-life of truth. What you're doing is you're exercising intellectual humility. Being a human, you have to be humble about your awareness of what else is out there, and most are not. So there's one analogy that really resonates with me from Chad Cook about going to an auto shop to fix his transmission. And pain science education is like a mechanic who comes out into the waiting room to explain everything that's wrong with your transmission, but doesn't do anything about your transmission. So it's not going to make your car run, but
Sassy.
it will make you understand the transmission probably a little bit better. So explaining pain doesn't make pain go away, especially when it's not an osteoplastic pain condition, right? So question for you, Dana, is clinicians are educated professionals. I mean, most invests some time and resources and energy to become educated professionals. But slowly, there's almost a pull towards this pseudoscientific practice. And at least in the United States, I believe this pull is as much economic as it is intellectual. The economy of scale is that people pay for things that feel good, not for things that work. So how do you teach this intellectual humility to practicing clinicians to allow them to update core beliefs when new evidence emerges?
Ask it a different way.
How do you teach? Can you teach? And how do you teach intellectual humility? Can you teach a professional to, especially someone who's been in practice long enough, to be epistemologically comfortable with their core beliefs, to back away? Can you actually teach someone who is good at what they do, or who thinks they're good at what they do, to question why they're good at what they do?
It's not easy. But I do think there are ways. Reading Demon Haunted World by Carl Sagan as you're entering your career, that'd be good. We talk a lot about this in the skeptical community. Critical analysis is a unique skill set that has to be learned. And education is deficient in this. And a lot of healthcare professionals, in some ways, are worse about this than anyone else because they have the illusion of knowledge, the illusion of skill with critical
That's
thinking
right.
in science. Because healthcare, when you learn how to be a clinician, it appears to be a science-based education. But what's missing is actual critical thinking and skeptical analysis skills. Scientific skepticism involves a whole bunch of very specific knowledge about how minds work, how knowledge works, how we fool ourselves, how science works. And that stuff just isn't in any conventional curriculum. It's always missing. The good news is, and to answer your question, is it is a very specialized skill set, but it's not that hard a skill set to acquire. It's relatively low-hanging fruit. If you can just get to the point where someone wants to learn it, it's not that hard to learn. The basics can be learned relatively quickly, but that initial step is very, very hard for the cliched reason that it's hard to get a clinician to understand what's wrong with a treatment idea when their income depends on not understanding it. And their income, and I want to acknowledge this. This isn't a criticism, heartfelt. Their income does depend on it.
Hmm.
And I know this because I've been there, because I made my living almost exclusively as a clinician by doing trigger point therapy, which is very enthusiastically criticized by a lot of skeptics. Just recently, someone commented on, I'm pretty sure it was a response to my article in The Skeptic about pseudoscience and physical therapy. I think it's worth quoting here. It's short, just a couple sentences. Every intelligent PT I've met, this is a PT talking, this is a physical therapist talking. Every intelligent PT I've met knows it's all nonsense, but we all got to get paid, so nothing will ever change. I know that 90% of what I do is overutilization or outright fraud, but I've got a family to support, so I just go through the motions. That's a PT talking. That's not me. I'm quoting.
I'm surprised somebody admitted that, frankly. And my only comment when you rephrased was people have to want to do something different.
Yeah.
When, in a lot of the early work, I was working with directors of rehab, my early value-based care work, working with directors of rehab on getting them to think differently about why is this patient still in your facility? What are the goals that can't be achieved by discharging them out of the facility, continuing to work on them? And out of 30 facilities I worked with regularly, I maybe over time reached 3 of them. We're both PTs. Let's have just an intellectual discussion about what we're doing. Most of the time they fought me harder than anyone else in the building. They pushed back. People deserve to be here. They've worked to pay for Medicare. We're doing what's best for them. And they've just been indoctrinated. The incentives of the building itself and what they were telling their physical occupational speech therapists was the right thing. What they told their social workers, their nurses, but you have to want to see problems that you want to fix if you want to ever hope to change. And that's just you. That doesn't mean you can influence a single person around you.
So earlier this morning, I had a conversation with a senior executive in a large system that operates multiple sites around the country. Essentially, it's a national chain, let's call it. And the argument there was that we don't need to know how it works as long as people get better. To me, that is a nihilist argument, right? So it is that straw man argument that it doesn't matter how we get from point A to point B, but if we're at point B, that the mission is accomplished. That counter argument for me was that any profession needs to have a foundational layer that identifies what is the expected product, clinical product. And that clinical product has to be substantiated by best available evidence, right? And as you were saying, Paul, that if it's not available, then you use level 5 evidence. I think it works.
Mm-hmm.
But without that substance, just to say that we know it works, we don't care how it works, as long as people get better. It is kind of scary. So if we're going to go back to that value-based care argument. So as U.S. healthcare system is making this transition, and we're slowly turning away from reimbursing professionals for encounter to reimbursing professionals for outcomes. we have to align with this base layer of truth and the entire argument of like 51% substance, 49% bullshit. Like, so 51% substance and everything else is bonus. But what is your defense? How do you, both of you guys, how do you stand up to that argument? I know it works. It works for my patients. I don't care how it works. Like that is that fundamental layer that therapists use, is that I know I get people better. That's all that matters. So what would be your argument against it?
It's the most common objection and pushback against evidence-based medicine. The conceit that we know what works for our patients, but we actually don't have that ability. It is impossible for clinicians to know what works for their patients. That'll get a lot of backs up right away, that statement. But looking at it from a scientific perspective, imagine a little thought experiment. Imagine that you were to design a scientific experiment that tested whether or not something works using exactly the same methodology as an individual clinician trying to decide whether or not their treatment is working for their patients. It would never be published. It would never make it past even the worst peer review. It doesn't come anywhere close to being good enough. And that's because we know very well from the history of science, from centuries of studying how this works, we know that things like this are spectacularly confounded. There are all kinds of things that warp our perception of what works with our own patients. And there are many examples, and that's the point. There are many examples, but I'll give one. You know, the simple is just sampling bias. People come to me because I'm the skeptical guy. They will come to me with their stories of extreme dissatisfaction and frustration with the physical therapy that they have received. And I ask them almost always, did you talk to your physical therapist about this? Did you talk to the provider? Nope, never. They never do that. So my point being, you don't hear from the unhappy ones.
That's right.
They just don't come back. It's a truism in tech, and I got a foot deep in the tech world as well, because I do all the programming for my own website. I'm a programmer, and I was a website developer for a while in the 90s. And so I know my tech, and I know that in technology, it's an almost comical extreme. If one person reports a bug, it means that there are 1,000 people who did not.
That's right.
And the same thing happens in clinical practice. If people aren't happy with what's going on, they won't tell you. You don't know the denominator. You don't know how many people reported satisfaction out of how many who weren't satisfied. You never know that. And that's a severe sampling bias. That's just one example. But again, the point is there are lots and lots of ways in which we really can't determine how well our treatments are actually working. And the only way to determine that is to control for the confounders, and that's science. You do a proper scientific experiment to figure that out. That's why we do clinical trials, because it doesn't work for individual clinicians to try to get a feel for that. So that's a long answer now. We'll wrap it up. Dana, what do you think?
I mean, I go to when is, the responsibility here is not just to be, practice evidence-based medicine, but when is it also causing harm? And, I'm overlapping topics between pseudoscience and treatments that are inappropriate for a condition, but you talk about a simple, super common thing we see every day in just traditional medicine. Somebody comes in, I have a stuffy nose. I must have some kind of bacterial infection. They don't use that. They just say, can I have an antibiotic? And rather than have a conversation about it and assume that the patient is just going to go to the next doc down the street, they give them an antibiotic for their cold. And yet we know it destroys microbiomes. There is damage to multiple layers of damage to taking antibiotics when you don't need it. Using a proven treatment antibiotic that treats and cures bacterial infections. And patients are victims of the system, not knowing that the system is not incentivized for them to get the best care or for the care that they're recommended to be provided. being best for them or even efficacious at all, or they're blind to it. So there's layers of things that are just terrible about this, ethical dilemmas. I mean, we end up harming folks when we do things that we shouldn't because it's easier. And we tell ourselves that, oh, it's not, as long as it works. Well, how do you know what you do works? It's so cocky, right?
Yeah.
Yeah. So there's a really interesting research on iatrogenesis of excessive care, right? So overtreatment has an iatrogenic effect. It's not just inert, it's not just neutral. So over providing care doesn't result in nothing. It results in health detriment. And that applies to physical therapy as well. And I think over provision of care or provision of pseudoscientific care or low value care results in worse clinical outcomes or health suffering by the individual, the very same people that come to you to receive care because it works. And this over provision of care leads to best of the worst, just passive coping with strategies. I'm just going to rely on you to make me better. And at worst, it results in worsening health conditions because your tissue, it requires load. And a lot of these pseudoscientific, a lot of passive care techniques actually don't improve physiological fitness of the organism. The things that improve the physiological fitness of the organism can be premeditated, can be calculated, can be objectified. I find the best, at least for me, strategy for the bullshit meter is the Toyota method, right? You do the 5 whys, and anyone who doesn't have substance usually falls apart by the second why. Like if you ask him, why do you think it works? Well, because A, B, and C. And why do you think that it works? So for them to be able to establish that causality, that causal error falls apart after the second why, because there's absence of the depth of knowledge. It's just a shallow, superficial belief system. And knowledge and beliefs are two different things. So if Paul, you're a skeptic, Michael Shermer, to me, is like pretty high up there on the scale of smart people. And for him, like he always has the anecdote that if you stop believing in gravity, gravity will still work. You're not going to float away, right? So that's the way you know the substance. So the question, I guess, for both of you is, do you think as a profession, and I'm going to even zoom out from physical therapy, do you think these health modalities that people pursue for pain reduction, for quality of life improvement, do you think they're too far gone because they're economically reliant on passive care? Or do you think there's a way to realign the profession to actually create this substantiated foundational truth that is founded in science and then build on it, rebuild the profession from that substance?
I think there's always hope. And I think this is my primary hopeful prescription for any healthcare professional trying to help people with pain and injury, which is that there's always hope for a minority. I think the profession as a whole has a very serious problem that probably can't be solved. But that was true for me as a massage therapist. I didn't have much hope for the profession as a whole, but I could easily see a path to a satisfying career as an evidence-based massage therapist myself. Whether or not it's going to be possible for that to spread and catch fire and move a whole profession forward, I think that's quite unlikely. I hope to be proven wrong, but I think that it's almost inevitable that in 20 years, we're pretty much going to see the same problems collectively that we do today. I don't have much hope for moving that needle, but I also absolutely know that individual clinicians can succeed in making a transition to a much more satisfying way of doing their work and a more effective way of doing it. It's always possible to focus on what works and what makes more sense. That's the best case scenario, I think, is that we can help a minority get there.
Yeah.
I mean, bouncing off of that, I'll say two things. First, we have a doctoral degree that is based on science and does prepare us to be a great diagnostician who can develop a robust evidence-based care plan. We are capable of that. At least we're educated to do that. Here's the tricky part for this profession to evolve. We've overcomplicated, we've looked for all these different solutions, but most of what we have evidence around is hard for patients to stick with, and that's really good strength training. Excellent strengthening that is well prescribed, that puts patients to fatigue, that builds muscle and strengthens and supports joints. That's most of what makes therapy efficacious. It also sounds so both simple, like others can do it,
Yeah.
and like something that requires so much patient compliance that then you feel like as long as you can do other things, you can justify long and frequent plans of care that you surround by these modalities, make them more apt to continue to comply, is what I've seen in some of the best therapists that are trying to do the most evidence-based thing and where they're layering other components. And I actually do understand that. But again, we should really be diagnosticians, develop plans of care, work with PTAs to carry out those plans. And most of the time, most of the care plans should center around strength training. And it sounds almost too easy. And I think we complicate things partly for that reason. Are we going to get therapists to buy into this? The truth? The therapist practicing now? I don't know. So,
Right.
Alex, prove me wrong.
So,
What
so
am I
I
missing here? Because you're in the field.
no, you're. I mean, you're right on. So there's a thought experiment that I usually play with other therapists, and can you say you had a successful clinical intervention when a person who pursued care through your medium leaves follow follows the encounter with more pain than before? It cannot be defined as a successful clinical. And to me is absolutely yes. You can have a slight elevation in the pain experience, being a subjective sensory experience, if you improve physiological fitness for your immediate environment. That physiological fitness is improved through this exposure-based therapy, which is strength training, neuromuscular education, different ways of improving your ability to interact with your immediate environment. At the same time, everything that we're discussing right now is not unique, I would say, to physical therapy. And I will give you more of an N equals one experience, which is there's an abundance of orthopedic surgeons that operate because they have vacancy in their OR, not because they see, right? There's always this gray area. Should I operate or should I just wait and see? The wait and see approach is wonderful. It is absolutely the best clinical modality you can give to your patients, especially when you see that patient doesn't have high layer of clinical sophistication, if the patient doesn't have multiple comorbidities. Sometimes less is more by even under providing care, by reassuring, by giving people a healthy dose of what the trajectory should look like, and then carefully stepping away from their picture. And the example of this, I don't remember who it was, but he would give people a prescription for nothing, a vacation from therapy. Here's your script, take a vacation from self-care. Don't do massage, don't do physical therapy, don't take your vitamins, take 2 weeks off and do what you enjoy. Go play with your kids, go do things that actually bring quality to your life. So to answer your question, Dana, and I want to see what Paul thinks about it, is that I think strength training and improving physical fitness through exposure, through resistance training work is definitely functional and operational because it hits into that base layer of human physiology. Use it or lose it. Load response, tissue-specific load response. But is it the only principle that works? Certainly, there's also a point of improving the mental models that help us exist in our environment through exposure. And physical therapy is that too. Physical therapy,
Yes.
good physical therapist, reduces catastrophization, improves your ability to be part of the
Yes.
world because you no longer have fear of being part of the world. And with this, I'll step away. And Paul, what do you think?
Many thoughts flashing through my brain as I listen to you talk about this. I want to first make a point that strength training is not just about corrective exercise. We're not just talking about making things stronger so that specific things work in specifically better ways. In fact, corrective exercise is almost a mirror image, evil twin of what we're talking about, I think. Corrective exercise is not good evidence-based care, but strength training in general is. The exercise therapy in general is. I want to zoom way out, though, now and talk about the fact that the ugly truth is that we, and I mean we as in all humans, the human race does not know how to help itself with most kinds of chronically painful injuries and problems. What I mean is, we don't have the science. We don't know how to accelerate healing. We don't know how to resolve most things that cause chronic pain. And this includes strength training. Strength training is really good medicine for some things, but I tend to frame it not as a treatment, but as an investment for reducing future vulnerability, for improving
Mm-hmm.
your odds of recovering in the future, of having fewer incidents in the future. And I do mean very specific prevention, such as preventing the loss of muscle mass and strength that comes with age, and osteopenia and osteoporosis and so on, preventing falls that cause fractures, etc. So very specific prevention. But I also just mean like improving the odds that in 5 years, the next time you have an episode of unexplained back pain, you got a better chance of bouncing back quicker.
Hmm.
Not for any specific reason, but just because you're generally healthier and stronger. Not a treatment, but an investment. So my point here is that we don't know how to get better quicker from most injuries. When someone is badly hurt, there is no method of getting them better quickly that is well established. But so that means that most of the value that physical therapists or any kind of health care professional can provide is in boring basics and expectation management.
Hmm.
And that doesn't sell well.
Yeah. Yeah.
It can sell, but it doesn't sell well. It has value, but it's totally tangential to what people expect and want from physical therapy. They assume, and therefore also a lot of physical therapists assume, but people assume the market demand is for body mechanic stuff. It's for, you're gonna fix me. You're gonna make it better. I'm going to come into your office and I'm going to come out better. And when they find out that you're offering something that's more limited, yeah, poof, a big percentage of them they're just gone. And so evidence-based practice is genuinely limited because the human capacity to help other humans solve painful problems is limited. And limited isn't impossible. Strength training is valuable, but it is a smaller, more boring sounding business. It doesn't pay the rent. Limited doesn't pay the damn rent,
Mhm.
which is really, really problematic. And so the ugly truth is that most clinicians will end up doing a lot of the same things that they've always done to earn money, just ideally with better framing and more informed consent. In other words, taking, a treatment that we really don't know if it works and saying, we don't know if this works. You want to do it anyway for upwards of $1 a minute?
Yeah, for sure. So I think to make a little bit of a connection to value-based care, so that
Hmm.
the entire economics of healthcare is completely reversed with
Yeah.
value-based pathways, right?
Yeah.
Where here you have an incentive to provide as little care as possible and only provide the care that's necessary, where your entire reimbursement model is based on only substantiating services to what you feel will maximize the return through minimal time and resource allocation
Well, and preventing avoidable care,
and preventing
right?
and sure
And
and
duplicative care, right? Which is where
which is
some of the
education.
greatest savings really comes from, which can be a lot of that communication, connection, relationship building.
So it would be exactly, and it would be really interesting to hear
Yeah.
Paul's opinion and Dana's opinion, where with that effort, there is now a movement in the U.S. physical therapy community to subspecialize. So no longer our specialties have to do with clinical philosophies, but they have to do with the mechanism of care delivery. So there's a movement to create a primary care physical therapist, which would be in an ideal setting will be placed in a system together with a behavioral health therapist and a primary care practitioner. And so when somebody has a complaint, they're going to be assisted to a triage of care by those three professions. And at the lowest threshold, it will just be a physical therapist that will be indoctrinated in either an emergency room or in an urgent care center or in a primary care physician's office that will oversee musculoskeletal complaints. Do you see that as an opportunity to create a little bit more of evidence behind clinical care delivery? Or do you see that as an effort to create another certificate, another reimbursable continual education pathway so that clinicians will then jump on that next philosophical train to get that extra letters after their name?
I want to hear Dana's comment on this because I'm not familiar with this movement. So you first.
Yeah, no, I'll just build on it a little. And I would say that all PTs should be able to, whatever they're doing right now, step into the role of seeing a patient and being able to do an assessment. So the way primary care is moving in America, paying for team-based care and paying practices for good outcomes that overall as a practice reduce avoidable unnecessary care, like specialty care that's not needed, like MRIs that aren't needed, like hospitalizations that could be avoided by, better management of conditions, easy access to the practice with, greater hours, et cetera. So in these primary care practices, what we see right now is primary care providers and advanced practice providers. So we have physicians, nurse practitioners, PAs, et cetera. And then behavioral health providers. So we have that primary mental health care, depression, anxiety, et cetera. They'll often have like a telehealth component where they can reach a psychiatrist if they need that additional medical care. And then we have a lot of times RNs and social workers that are doing some of that care management, maybe doing, addressing social determinants of health, other things. What we haven't seen yet, and I blame our profession for not paying attention to the trends that where we could so easily step in. You have a patient coming to primary care with an MSK complaint or, abnormal gait when they need gait training or balance issues or, painful shoulder, OA, you name it. The physician can't do much. Physicians in America, they don't treat primary musculoskeletal care unless they're orthopedists and they're screening essentially for PT or surgery. They're just making a triage decision. So embedding physical therapists in these practices would help elevate the profession to one that is doing evaluation, triage. It may be evaluation and follow-up. It may be evaluation and, if they do believe they need to see an orthopedist, for example. I can't imagine a therapist that doesn't understand that we belong in primary, urgent, and emergency rooms. There's lots of ways therapists could approach primary care practices and offer this. I mean, we're preaching it as often. Preaching that doesn't necessarily work. You have to want to hear the message. But that kind of a specialty would elevate the profession. You coming from the pain science expert in evidence-based medicine, just kind of hearing that overview, any initial reactions or like things you would push back on?
Well, I did a lot of nodding there because it makes sense to me. I think that the majority of, well, I shouldn't say the majority, a large percentage, obviously, of complaints that primary caregivers get are in the pain and body pain and musculoskeletal category. And so many, in fact, that it would make sense for physical therapists to be very close to primary care, to be a frequent referral, ideally. Knowing that it's extremely common for people to get told that their glutes aren't firing or to get put on an ultrasound machine.
We're talking ideal
Yes,
evidence-based practice.
Yes. If done the way I'd like to see PT done, then I see it as being an excellent fit for that scenario, for being more tightly integrated with primary care. Because I think, I said it a few minutes ago, it just flashed by, but I said that the reality is that what value there is, what we can do for people is boring basics and expectation management.
Yes.
Was the phrase I used.
We're better at it than PCPs are when it comes to MSK care when done
Absolutely.
well. And
well
one
done.
other thing I didn't say that is because you're not familiar with value-based care in America. I don't know any PTs are unless they follow
Most
us
people
and
aren't.
understand it.
Yeah.
But in these practices, America, like I was explaining, you do more you bill for more things and you get paid more. But in advanced primary care practices that are in these value-based arrangements, they're not paid based on transactions. They're paid by the payer or the plan sponsor monthly to manage a population based on the risk of the population. And the number of interventions done has no impact because you're responsible for the entire annual budget in and outside of the clinic. So it is in a direct incentive to provide exactly what people need. Not less than they need, not more than they need,
And not
but
more than they need.
exactly what they need. Again, the perfect way to teach therapy how to practice at the very top of scope, knowing the practices, including their incentive, is avoid high cost care, provide exactly what people need when they need it, quick access. And a lot of it's about, to your point, managing expectations, communication, calming, teaching, right? And preventing them because they get that tight, positive experience, not like the complaints you were talking about. They don't run off to get an MRI or run off to the orthopedic surgeon.
I was waiting for the opportunity to inject that example. Yeah.
Yes.
Specifically to prevent premature MRIs for back pain. That would account for a very large percentage of the expectation management. Yeah.
So does that So you're generally not to feed you, to prompt you, like, does this make sense? Because we're telling you. And I know there's other research to do, and you're not the person that's going to be like, I 100% agree, but directionally,
Yeah, no,
right?
it's one of the things I like to see. This is you're describing a fantasy of mine for this field. There's all kinds of details that we could discuss. Maybe we wouldn't agree on all of them, but for sure the general direction. This is exactly what I would hope for. And if there's a path forward to a better future for the profession, this strikes me as a great one to pick. This is exactly why I plugged this podcast on my socials this morning, because I wanted to introduce people to the idea of value-based care as an alternative to FF care for fee-for-service. And I barely knew it existed until recently. So
Yeah.
it's kind of shocking how if this is a fantasy of the future, how come I didn't know about it sooner? Because I thought about all of the things that were involved in it without ever really hearing that it was an actual movement.
Yes.
And
So
I'm
to be
glad to hear that it's an actual movement. Yeah.
uh,
Yay. I know. It's a movement that primary care medicine has been. Yeah, the early adopters were now dragging along the mid adopters, and about half
Yeah.
of primary care practices are in some level of value-based care. Only a
Yeah.
small portion are taking what they call full delegated risk. They are the ones, the practice itself, the primary care team and the owners, they're responsible for total cost of care. If their patient goes to the hospital, it comes out of their pocket. If the patient gets an MRI, their pocket, what's left is what they keep, essentially, right? So there's a small portion that are there, the ones that are doing it and doing it well. A lot of them have taken years to get to that full risk. They're doing really well. I mean, there's the opportunity for primary care to take a much larger share of total healthcare spend by providing the right care at the right time and taking time with patients. Essentially, that's a lot of what it is. Connecting with people, being available, right? Knowing them, having the data to know who needs them. That's the bottom line. And PTs, we're 10 years in. I don't want another 10 years to go by before we say, oh, why didn't we know about this?
Mm-hmm.
so I'll give you a good point of reference. Like I'm a techie, and so if you look into the evolution of artificial intelligence, from its foundation at MIT in 1950s to current iteration. So you're talking 70 years of on-ramping with a lot of false starts. AI from concept to theory to computation to modeling to current large language models and beyond. It's 70 years of unwrapping. It's a slow churn, and so there were a lot of these dead zones. There's a lot of AI winters through this iteration, like where you would get a false start. Usually, it would happen when the environment was not ready for acceptance of artificial intelligence. Either the computational power wasn't there, utilization, or the end users weren't ready for it, or the cost of jumping onto the artificial intelligence was not present. So the equivalence here is for value-based care. Potentially, like, it's been around since 2008, the theory. But then every false start was because the environment was not ready until now. So in 2026, I think the environment is ready. We're primed
Mm-hmm.
for it. We're like, especially in the United States, dudes, we're spending like trillions of dollars for healthcare that is mediocre at best. Number 35 country in the world in terms of clinical outcomes, and number one and above in terms of how much we spend. Uh, I want to be respectful of your time, Paul, to make a full circle too, to finish off our conversation with just a single question, which is if you can mentor a young clinician, if you can mentor a student, or if you can
Oh, no.
mentor
Uh-oh.
a therapist, like, and because we started this with a pseudoscience versus science, what are some of the things this cohort of up and coming, where like they're not like me, who's already like on the other side of that curve, but who's actually has an entire career ahead of them? What do you look for to ground your practice, to ground your professional etiquette in something that's more science focused, science guided? How would you go about it?
I say Because it's a really hard question. And it's closely related to what we said earlier about, how do you inspire people to start questioning what they're doing and looking for a better way of doing it? And there are no easy answers to that. And I think for so many people, it's going to hinge on the question of how you reconcile good care with business survival. Most people aren't going to frame it this way, but they're going to be emotionally reacting to it like, yeah, but how do I make a living with this evidence-based care stuff? The first level of resistance to evidence-based care is usually the emotional threat that any challenge to anything you believe, the threat to identity. We essentially react to criticism like that emotionally, like our identity is being attacked. But right under that, right behind it, is the intense practical problem of, yeah, but how do I make a living with the boring basics and managing expectations? How can evidence-based care uh, pay my rent? And I think you've got one great answer. Like one terrific answer is, well, listen to this podcast, learn about value-based care. That's one great answer that I'm delighted to start adding to my own list of possibilities. But more basically, how do you do this in practice right now, today, tomorrow? I think that you are candidly humble and honest about the problems. People reward that. Your integrity and humility become the product, and some people will buy that. In fact, quite a few people will buy that. I used to try to fire my clients because I was always concerned about excessive care. I was always concerned about the fact that it was, the cost, the time, and the evidence, the poor evidence were wildly out of proportion, that I was basically doing too much with too little clear evidence of benefit. And so I would try to get rid of people, and I would insist that we not continue unless they had a very strong feeling that it was worthwhile. The extent to which I was rewarded for that is incredible. People would tell me over and over again, well, you know what, you're right. I'm not sure this is helping, but I just appreciate the fact that you're so concerned about that so much that I'm just going to keep coming.
I believe that.
The people really will reward that. They love that kind of humility. They can become fiercely loyal to that. I think that PT faces a particular problem. I've always been able to reassure massage therapists because what massage therapists do can always, if nothing else, it can be a pleasurable experience. It can be an aesthetically pleasing, relaxing, pleasant experience. And that has inherent value.
Yep.
Independently of medical goals. It is much harder for physical therapists to fall back on giving people a aesthetically pleasing experience, a pleasurable experience, but there is an equivalent, and it's basically social, that you've got to provide a social experience and an intellectual experience that is reassuring and comforting and encouraging and empathizing. You got to be really, really good at the soft skills in the profession. You got to be a great communicator.
Yep.
You got to be charismatic. You've got to be not just reassuring and encouraging, but reassuring and encouraging substantively. You
and
got
very
to
authentically.
And very authentically. And that, if you combine that with, very candid acknowledgement of the problems and limitations, which people will reward, I think it's you can have what looks like a pretty conventional old school physiotherapy practice that is still nevertheless successful and does pretty well without any ethical squeamishness as you become more and more aware of how many treatments don't probably work very well.
As long as you're not billing a third party when you're not providing evidence-based care. I mean, that's the other issue we have is, we need to treat the general public and provide that frontline musculoskeletal care. Who talks about this a lot, and I believe listening to his podcast and speaking to him, that he sort of built his practice around this, is Tony Maritato, who's a relatively well-known for teaching therapists how to bill properly in Medicare and other things, but he has a podcast. But he talks a lot about how he does, really traditional care, But he has this environment where, once patients are done, they love being there so much. He focuses on it being a community type environment where you get to know the other folks that are going there. The people that are going there to participate in the exercise program. And then you can continue to come just as a member of essentially the gym where there's therapists present
Mm.
and participate that way. And it is that camaraderie where, people continue to come. And then when they have another issue and they want to, have a justified reason to start PT again, they're there already. And so there's this kind of cyclical benefit. Sometimes it is through something that's reimbursable. Other times it is because he's developed this kind of community. He is a fixture in the community and has his own community within his practice. So I think
Mhm.
that's just I like to say value-based care is about communication and connection. And really, that
Yeah.
comes from me knowing what you're saying intellectually, right? There is lots of evidence for some of what we do, but again, you have to be ruthless in being able to determine what that is and then being able to communicate with folks when it's not, when you're providing something that we don't have great evidence and we're not telling people. We could say it's unethical.
Yeah, I would close off with just one statement. I think what you're seeing in United States is a propagation of negative feedback loop where hustlers got rewarded and smart evidence-guided therapists got burnt out and left the profession. So
Mhm.
you have this natural evolution where sharks went to the top and tortoises went underwater. We are tortoises because we still are passionate about the field, but the entire industry, especially the commercial part of the industry, systematically rewarded financially and positionally therapists that could care less about evidence, but were deemed hustlers that they could maximize volume, maximize number of units, regardless of clinical efficacy, regardless of clinical need. So here we are, 2026, time to change. And we hopefully are agents of change. So, Paul, I want to thank you for dedicating so much time to this. I think, again, if anyone can, if you have a last message where people can follow you or they can find you, if there's any point where anything else they we can be of service to you, go ahead if you don't mind saying it.
Sure. I'll get to plugging my stuff, but before I do that, can I add one more point?
Yes.
Something else to help that young therapist just starting out. There's a very clear off ramp from the dubiousness of manual therapy to more evidence based practice. You can actually do all the manual therapy or most of it. It's possible. The trick is informed consent. You just have to frame it differently. If you are honest with patients about the fact that we don't really know if or how this stuff works, but in some cases, the experiment is justified. Here are the possible harms. Here's what it'll cost to try. Here's what we know. Here's why it might work. Here's why it might not work. That is completely ethically different. 100% is the polar opposite of saying what you need is to get rid of this fascial distortion. So here you go.
Can't get docs to say that when someone's dying and they're about to
Yeah.
get their last chemo a day before they pass away. We're
Yeah.
asking PTs to do it now who make a fraction. So that's
Yeah.
what makes me, yes, I agree 1,000%, but is it realistic?
It's an option for the tormented newbie in this
You're right.
profession to know that yeah, you can still do manual therapy, just frame it differently, please. And that will be you're on the right side of history if you get informed consent for what you frame as an experimental therapy, because that's the bottom line. And most people aren't used to thinking about manual therapies like that. They're not used to thinking about stuff that's been conventional in the profession for decades as being experimental, but it effectively still is. Some of it might even still pan out if it ever gets studied properly, but probably not much of it. Just reframe it as experimental therapy. That goes a long way. And it'll also score you great humility points with people on a social level. They will appreciate your candid honesty. I think that a lot of clinicians have this vision, this nightmare that if they admit that they don't really know if this stuff works, they're going to lose all of their clients and be laughed at.
Yeah, you're
It's
right.
not how it works. It turns out that if you just tell people, yeah, stuff is hard, we don't really know what works, and we don't know if this works, but it might be worth trying for this reason, and let's talk about the pros and cons. People love that. It is, in fact, specifically and exactly what people think they want from physicians and aren't getting. Because they are. So they're generally not getting it from any kind of healthcare professional. So I wanted to
You're
throw
right.
that in because it is a dead easy thing to do. It is essentially, there are a million people out there who are doing their job in a way they could change absolutely nothing about what they're doing on a day-to-day basis with their patients, except that reframing, and it would be a huge upgrade. So that's my final point. My whole thing is on painscience.com. I make my living by writing books and selling memberships for exclusive access to my best stuff. Like, for instance, I have a podcast, but nobody knows about my podcast because it's private. Only the enthusiastic, nerdiest patrons get to listen to the podcast. That's been going on about 2 years now. Maybe I'll have a public podcast someday, but I kind of like it. I like how it's working out to just record things for my members. So painscience.com has, of course, all the information about all of this stuff. But just start by best thing you can do is to get to know my work is just subscribe to the newsletter, painscience.com/subscribe. You can start for free. Don't have to pay for a thing, and just follow along for a while until I hook you, till I get you with something you just have to pay for.
Who are your members? Are they physical therapists,
Yep.
physicians, massage therapists, all of the above?
All of the above. Is probably dominated by massage therapists because that's where I started. I started out writing mostly about massage and massage adjacent issues. And, my early audience was almost 100% massage therapists, but also patients. And this is what's weird about me. Unlike almost anyone else, I can't think of anyone else. I do this thing where every single thing I write, I try to make it suitable for both patients and professionals. And that is a balancing act that there are days when I regret trying, but I really, really work hard to make it relevant to both professionals. Because the reason it works is because the Venn diagram of what patients and professionals care about is what works.
You're right.
That's where we all meet in the middle is how do we do this? How do we solve these painful problems? How do we help people feel better? How do we get better? That shared curiosity is the common denominator for both audiences. So I have this bizarre situation where I've got a fairly large audience of roughly equal numbers of patients and professionals. And that is an oddity for sure. So
Mm.
join in, help increase the professional side of that.
And please, please, please find Paul,
Yeah.
find his blog, go to Pain Science. Like the lowest threshold of knowledge is actually acknowledging that Paul exists. His blog is there. Know that there's people that
Right.
have been on a mission to bring literacy, scientific literacy, to the masses of healthcare professionals, and you are it. So, if nothing else, you are going to come out to be a better professional and a better human by being aware of the source of grounded truth. So, Paul, thank you for this. It has
Thank
been
you.
an absolute pleasure, and I really hope that we will have you on potentially in the future to discuss some of the progress we're making.
Thank you so much. Yeah, it's just a breath of fresh air. It's fun to talk science and blunt conversation about our profession. We wouldn't do this if we didn't care about the profession, but we want to see it elevated to what's possible and not become extinct. And if we
We
don't
criticize
go,
with love.
Like any good parent should.
that's right. I do the same to medical providers, exactly the same. If this episode made you uncomfortable, good. That means you care enough to question what you do and why you do it. The point isn't to tear down physical therapy, it's to make it better by being honest about what we know and what we don't know and how we can talk to patients and each other about the difference. Paul's approach is simple. As he explains, you should treat uncertain interventions like experiments. You should know what is and is not a certain intervention and where the evidence may be more murky. And you should get real informed consent and don't oversell what you can't back up. So it's not like we're saying abandon manual therapy or scramble to change everything you do overnight. But there is some reframing of practice that many of us need to do if we're really being honest and humble about, even gaining a competitive advantage rather than liability. The boring basics, they work. Strength training, movement, patient education, they're not always sexy, but they're defensible and they work. And we have good evidence around them. When you combine that foundation with transparent communication, something that therapists are highly skilled at, you build trust that lasts longer than any single treatment could anyway. We hope this conversation leaves you thinking about the evidence behind your treatment plans, makes you think about the science of pain management. Definitely visit painscience.com. It's an excellent resource, has some, super resources and research within it. And think about how you can provide great care without compromising your integrity or your livelihood. The future of physical therapy depends on clinicians who are willing to ask hard questions and to practice so that they are on the right side of history. Thanks for being here again with us on episode 25. Please like this, please subscribe, and the best thing you could do is to share it with a friend.